Good morning, everybody, or good afternoon. I'm not sure what time of the day this will be. This is Professor Andrew Wright. I've been asked to talk to you. I was originally asked to talk about treatment of late stage, particularly stage 4 melanoma, but I didn't feel that I had the knowledge and expertise to talk about monoclonals and the newer treatments and trials that were going on. So I was sort of given carte blanche, and I thought that given that I've actually just retired and got some 30 odd years experience in skin cancer, it might seem logical to choose some of the areas where I think I can pass on little gems. And I was also asked to talk about dermoscopy. So what I'm going to do in this talk is I'm going to talk I've entitled it miscellany. I'm going to talk about lesions that can catch you out a little bit, and that you need to be careful and wary of. I've considerable expertise and knowledge in medical negligence cases because I do a lot of medical negligence work, so I thought that I'd do a section on where things can go wrong and how they go wrong, because I think it's relatively easy to avoid some of the pitfalls and things that go wrong. And I'm going to finish off with a little bit of dermoscopy, but not a lot. It's a little bit unfortunate that we've got to deliver this talk in this way. I always think that small groups, and I'm assuming this is a relatively small group of people, gives you the ability to do a sort of seminar type, workshop type thing, and clearly I can't get questions and feedback straight away. But if anybody having seen this wants to ask any questions, then the easiest thing to do is to email me on the hospital email account, which is andrew.wright@bthft.nhs.uk, and I will be very happy to answer any questions or queries about the slides or any other questions or queries about skin cancer in general. The other thing I will apologise for as well is when I went through this last night, and it might show better when you see it, but when I went through it last night, the quality of some of the pictures isn't as good as I thought it was, and that might be because of the way I've copied some of them, and I apologise, but unfortunately there's not a lot in the current circumstances that I can do about that. So let's have a little look. I'll introduce each slide as I go through so we don't get out of synchronization. This one starts with the title Unusual/Difficult Skin Lesions, and this is a picture of a lesion which is in fact an amelanontic melanoma. I would challenge anybody to be sure that that's what that was, but I think it's a reflection of how skin cancers can present. And I mean, this could certainly be a melanoma that had a reasonable Breslau thickness, so you always have to be on your guard. And I think it's always important to take a history from a patient and not just look at a lesion, and I'll come back to that a little bit when I talk about dermoscopy at the end. But if a patient clearly gave you a history of this lesion having failed to respond to creams or ointments, given that the GP might have thought it was eczema and that the lesion's growing or changing, then it clearly needs a biopsy in order to establish a firm diagnosis. So I'm going to go through lesions that can catch people out a little bit, and one of these is pyogenic granulomas, and we've got a picture here of what is almost certainly a pyogenic granuloma. It's on a typical site for a pyogenic granuloma. These usually grow fairly quickly, they bleed relatively easy with mild trauma, and they're basically harmless lesions, but they can mimic other lesions, and other lesions can mimic pyogenic granulomas. This is another picture of a pyogenic granuloma on the forehead. So this is the third picture slide, sorry. I said I'd introduce the slides, so I'll try and do my best to do that. So this is on the forehead, but this is a pyogenic granuloma. It does have a little bit of pigmentation there, but in fact that's almost certainly just because it's bled, and that would probably wipe off. I have on occasions had GPs who've removed lesions that they thought were pyogenic granulomas and not sent them for histology, and then the patient has later presented with either a recurrent melanoma in the site of the lesion that had been treated, or even metastatic disease. So even something simple as a pyogenic granuloma should be sent for histological examination if it's going to be removed. This next picture is a picture of an amelanontic melanoma. and I think you can see that this looks a little bit like a pyogenic granuloma. If you look at it very carefully, I think there's a smidgen of pigmentation at about 4 o'clock or so, which might give you a clue. But again, I challenge anybody to be certain what this was, and I think amelanonic melanomas are a big catch as far as diagnosis is concerned, and do look very like pyogenic granulomas. This next one, this flat lesion with some discoloration around it, is in fact another superficial spreading amelanontic melanoma. I think again that with the eye of faith there's a little bit of pigment here which might, if you looked at it very carefully, suggest there was something worrying or sinister, but this isn't a particularly worrying looking lesion, and I could see that people might think that it was a basal cell carcinoma, but again the history would suggest it had grown steadily and that it warrants a biopsy. So something not to be caught out with. This is a lesion on a toe. This isn't a pyogenic granuloma. Again, this is an amelanonic melanoma. The toes and the feet in general are a common site for amelanonic melanomas. Quite a significant number of subungual melanomas on the feet are amelanonic, and again I've seen patients who've been treated and managed by from their GP with either a pyogenic granuloma or a chronic paronychia, which has become inflamed and use the words inverted commas, got granulation tissue around it, which in fact the granulation tissue was an amelanonic melanoma. Clearly later on lesions become very large, and obviously this next picture, which is entitled, spelled wrong, Acral melanomas, is fairly obviously something sinister, but again it's amelanonic. This needs a biopsy, and is obviously quite a worrying lesion, as it's almost certainly going to have a significant Breslau thickness and will require fairly major surgery. Another area that catches people out is pigmented streaks in nails. Pigmented streaks in people with racially pigmented skin are relatively common, and I think looking at this picture here, the first picture I've got of a nail streak, you can see that there are discoloured streaks to several of the nails here, and certainly I would have no great worries about these at all. Looking at the next picture, this is a broader pigmented streak, and there is, I think, a little bit of pigmentation spreading onto the nail fold, and certainly this is a much more worrying feature. One of the features that I think this picture does demonstrate a little is what is, in my opinion, one of the most useful signs, and in a sense I think more useful than Hutchinson's sign, which is the so-called spreading pigmentation onto the nail fold and proximal nail area, is that I think you can see that this streak is getting a little bit broader proximally. That would suggest that there was a growing or changing lesion in or around the nail matrix area. Given that we know that nails grow over a 3 to 4 month period, that would suggest that this lesion was changing relatively quickly, and I certainly think that although we're probably not going to find anything dreadfully sinister here from a Breslau thickness, there is certainly a lesion which requires surgical removal. Going on to the next picture, a much broader band of pigmentation. There's no spreading pigmentation onto the nail fold, but pigmentation of a band that was that broad is not what I would describe as physiological pigmentation. In other words, even if this was in somebody with naturally darker skin, I wouldn't expect to see a band as broad as this in the nail, and I think this warrants a biopsy at least in order to ascertain what's going on. The next picture is one of these that is the common referral, that is to say, please see this patient who's developed an area of pigmentation in their nail. The useful clues here are that the pigmentation is not in the form of a streak, and there is an area of apparent clearing proximal to the area, and this really has to be a bruise. It is said, although I don't think you can say this absolutely categorically, but it is said that there are no melanocytes in the nail bed, and therefore you cannot develop a lesion which is pigmented partly beginning partly down the nail. In other words, any pigmentation that is appearing in the nail has to have emanated from the nail matrix and therefore from the proximal nail fold, and to be a streak. And anything, even if it's quite dark in colour like this, is much more likely to be a bruise. Clearly, if this is a bruise, it's likely to grow out, and giving it 4 to 6 weeks, which is about half the length of time it will take for a nail to grow, should enable you to see the area proximal to the discoloration gradually enlarge, which again is extremely reassuring and means that you don't have to perform any further investigations and that you can reassure the patient. Going on to the next slide, the other catch that we see sometimes is the development of pigmentation or discoloration in or underneath the nail distally. This is an example of a patient who has what's called onycholysis, that is to say the nail has lifted and left a gap between the nail and the nail bed, and what is quite common is for this to be colonized with Pseudomonas, and this is very much the colour feature that one would see with Pseudomonas. Sometimes the discoloration can be darker, but it's usually a very dark green colour and isn't in any way worrying at all. Occasionally this is also associated with a fungal infection, and it's probably worth taking a nail clipping, or somebody taking a nail clipping at least, to exclude a fungal infection. Strangely, Pseudomonas is very sensitive to vinegar, and if I see patients with this sort of discoloration, then I would suggest that they soak the finger in an egg cup with 50-50 diluted vinegar for 10 or 15 minutes every day, and the discoloration will disappear fairly quickly. Again, there's a couple of pictures of nails here which are dystrophic. I think the first picture on the left is clearly something worrying which has damaged the nail matrix, stopped the nail growing, and is clearly a melanoma. I can see that the picture on the right might be mistaken for a chronic paronychia by the inexperienced, but we've got some actual loss of nail here. Usually with a chronic paronychia, the nail will be growing into the flesh, producing granulation tissue, and that's not what we've got here. So although I wouldn't be certain whether the right hand picture was of an area of subungual bones, which is relatively common, squamous cell carcinoma or melanoma, I would certainly say that it necessitated a biopsy for diagnosis. A catch around the nail, and again it's something that's often sent to fast track clinics, is this so-called mucoid or myxoid degenerative cyst of the distal interphalangeal joint. These are relatively common. The picture on the left shows the cyst probably still intact. What happens here is the cyst is an extension of the synovial capsule from the distal interphalangeal joint. It produces a pressure effect under the proximal nail fold which indents on the nail itself, producing this very typical groove in the nail because the nail's soft in the distal periungual area. When the cyst ruptures, which it usually does, and settles down, the nail will start to grow back normally. So we're looking at the picture more on the right. I think I've got a couple of other pictures of, so that's the next two pictures are a myxoid cyst nearer to the distal interphalangeal joint, and then a much larger cyst producing a groove in the nail, which again is an interesting groove because it's broader proximately than is distally, suggesting that there's a growing space occupying lesion in the proximal nail fold. I have to say that if I'm convinced, and I think the groove in the nail is a very helpful diagnostic clue, that this is a myxoid cyst, then although I appreciate they can be operated on, and patients occasionally do have them operated on, the operation is in my opinion quite fiddly. The lesion may recur, and I usually encourage patients to ride these out as they almost always settle spontaneously, and once they have done, they don't usually recur. But it can be a catch, and it's certainly something that's commonly referred to the fast track skin cancer clinics. Other lesions that we see which can be a catch are dermatofibrosarcomas. They're uncommon and people often don't recognise them for what they are. I've certainly had a case where a GP had sat on a scalp dermatofibrosarcoma for a significant period of time because they thought that it was a couple of inflamed epidermoid cysts. But usually the appearances of the area are on the right hand side, and there will be a history from the patient saying that the lesion has grown steadily. Clearly these are important lesions to diagnose. They're not uncommon, and I think within the dermatology service in Bradford we probably see 3 or 4 a year. They clearly require quite extensive surgery with a wide margin and should actually be managed through the sarcoma team in Leeds, but they are a catch because they don't have any particularly typical features. It's quite unusual for that diagnosis to be made clinically. Lentigo maligna is another catch. Sometimes they can be very subtle in colour. They're not always as obviously variably pigmented as this, and although it's said that most of them are on the face, they're not always, and certainly we see quite a number on the trunk. I think if you are suspicious of a lentigo maligna, then you need to perform a reasonable sized incisional biopsy. Unfortunately, I'm aware of a number of episodes and cases through my medical negligence work where patients are not routinely followed up if a negative biopsy is received, and I think it's extremely important, we'll come back to that again in the next section of the talk, that if the clinician who saw a lesion has written in the notes query lentigo maligna and the biopsy comes back as harmless, then a face-to-face review of the patient or a further biopsy is almost essential, because clearly one isn't going to recommend excision of a lesion necessarily on the head and neck, particularly if it couldn't be repaired with primary closure. But if we do an incisional biopsy and it doesn't produce a result, then sometimes it's necessary to re-biopsy. And again, the next picture is of 2 rather subtle lentigo malignas. They were both confirmed on biopsy, but you can see here that the features are subtle. The one on the right hand side is almost certainly one of those that may be self-resolving in the centre, or it may have an amelanontic centre to it. But both of these are lesions that the initial biopsy may not confirm the diagnosis, and if a service writes to patients with biopsies of apparent benign lesions, then it's possible that somebody with a lesion like this might get discharged. And it's important to review the clinical documentation when writing to patients with regards to benign biopsies. I'm going to move on to pitfalls and errors and things that I've seen go wrong, and hopefully help you to stop them going wrong in the future. Some of the common things are the wrong site surgery. I think it's absolutely essential that all patients who are going to have a lesion removed have it marked. We always do that in our service, but most of our service is a one-stop service, which does make it easier, but obviously it's the doctor in clinic who sees the lesion is not necessarily the person who's removing the lesion. I think it's always important to ask the patient to double check, and the use of a mirror, and particularly a handheld mirror, is important. I always think also that there is a difficulty. It's almost like giving a patient an information leaflet and making sure that they can read. You wouldn't always ask a patient if they could read if you give them an information leaflet, but if you mark something on their face and you ask them to check in a mirror, sometimes patients will be a little bit embarrassed if they can't see it easily, if they haven't got their glasses on. So I think it's important not only to mark it and ask them to check the site, but also to put their glasses on if they need to, and make sure that they are certain that that's the lesion that you're that both of you are talking about the same lesion. When patients are being seen in one service and operated on in another, then photography is of great value. One of the things we've certainly taken to doing in the skin cancer clinic if we're referring patients through, because we see them at St Luke's and the operation's done at BRI, is to ask the patient in the skin cancer clinic to take a photograph of the lesion with a marker by the side of it on their own mobile phone, and to take the phone with them when they have their surgery. And this can be extremely useful, particularly when we're doing further surgery to excision biopsies, because sometimes by the time a patient attends for further surgery to an excision biopsy, the excision biopsy site has healed so well that it's almost impossible to see the site. We also send patients to medical photography for photographs with markers on, and we often do that particularly if we're sending patients to Leeds for Mohs surgery, because by the time they get to the day of their surgery, it can sometimes be many months after they've been seen in clinic. Then the site can be sometimes quite difficult to note. I have seen on many occasions when there have been two histologies, the wrong histology put in the wrongly marked pot. This shouldn't happen. It's always been my policy to call the body site and to check the pot, and that's what we do at St Luke's. We write on the pot, on the outside of the pot, we call it, and we make sure that the specimen goes into the pot. It's always been my personal action to put the specimen into the pot myself, and to never get into the habit of putting the specimen onto the operating tray if I can help it. On a number of occasions I believe that has resulted in a lost specimen for one reason or another, and I think if you put it into the pot, call the pot, and the pot's properly labelled, you've done your best to make sure that you're not going to mess up with the histology specimens. Occasionally we can get patients who get the wrong label on the outside of the pot. Again, this is something that shouldn't happen, but very rarely you will get two patients with the same surname, one after the other, in theatre, and it's just down to everybody to be vigilant and make sure that the labels on the pot relate to the patient and the labels on the histology specimen relate to the labels on the pot. Lost specimens again are something that does happen occasionally. It shouldn't happen. One particular episode where I lost a specimen, and it's I think probably the only time I lost a specimen in theatre, was when a patient fainted, went on to have a mild to moderate epileptic fit, and by the time we picked up the pieces we couldn't find the specimen because it had got put on the tray, and the tray had got moved because there was a need to be closer to the patient. So again, it's a matter of vigilance, and I think if you put the specimen in the pot as soon as you've removed it, then something like that is unlikely to happen. Other things that I've seen happen, I've had a number of cases where a patient who's had a skin lesion, and this is usually a melanoma, has been back for follow-up and they haven't been thoroughly examined. We know that patients who've had a melanoma are much more at risk of developing a second lesion, and we certainly pick up quite a significant number of second melanomas. I've seen a number of patients for negligence claims who've developed a second melanoma after their primary, and when we've gone back through the notes, they had not been thoroughly examined and the melanoma had been in an unusual site that they couldn't see, such as their back. So I think it's very important to always examine a patient when appropriate, and it's also very important to document that you've examined the patient so that we know that the examination did take place. If from a medical negligence point of view, a judge will say that if it isn't written down, it didn't happen, so make sure you've documented it. Something that isn't always as easy as it might sound in the modern day of electronic patient records. I'm going to move on to treatments in a minute with the next slides, but if those of you who don't know what the Montgomery case was, Montgomery was really about an obstetric case in Scotland where the mother was not warned of the risks of vaginal delivery, not offered any alternatives, and there were serious complications around the delivery, and the mother complained. and the case was taken to the highest courts. And basically the outcome of Montgomery is that a patient really needs to be offered all the options available. In other words, and I think this particularly comes with certain basal cell carcinomas, the patient really needs to be told that they can have cryotherapy, curettage, creams, ointments, surgery and Mohs surgery, etc. You may spend some time making sure that you point them in the direction of the treatment that you think is most appropriate, but it's important that you discuss with them that there are other options. This comes on to my next slide, which is how to avoid complaints. I think it is very important to explain treatments and their options very carefully, particularly helpfully in the elderly, and if the elderly have got relatives with them who can reinforce this. But time and time again, particularly I think with patients who we've seen in the joint skin cancer clinic and who've had surgery to their lower legs, patients haven't fully appreciated the way the scar will appear, or the nature of the graft, the fact that the graft might not be the same colour, and particularly with a melanoma that the graft is going to be depressed and not flush with the surface of the skin. All these are important in making sure that the patient is aware, and I think in a sense if you make the patient as aware as possible, they're sometimes very impressed with the surgery because they were expecting the worst. With topical treatments, I think it's also extremely important to explain the type of reaction that a patient is going to get. We use a lot of Epidix and Aldara on our patients to treat Bowen's disease and actinic keratosis and basal cell carcinomas. Some patients will get an extremely florid reaction to these treatments, particularly Aldara, which works by stimulating the immune system. Many patients who use Aldara get a more florid reaction each time they use it, which does mean that they need to use it less frequently and for less length of time. But it's very, very important that you warn them. And I think if you don't, then you're bound to get complaints. There are information leaflets available. The BAD website has easy to print out information leaflets on the safe use of Epidix and Aldara and what to expect. This next picture is of a patient who used Aldara, though you can see a similar picture with Epidix. What often happens with Aldara is that you put the Aldara on one small area, but in fact you get almost a blunderbuss type reaction across the adjacent areas of skin because of the way the immune response works. And I think it's extremely important to warn the patient that that may occur, otherwise you'll get a phone call and need to see somebody very urgently to explain the situation. The thing with Aldara as well to warn patients is that you can get this quite striking hypopigmentation that you can see in section B, which is also in section D. This hypopigmentation gradually improves with time, and it's obviously not a huge issue if it's on body sites that are fairly hidden from cover. But if you're going to use Aldara on, say, a large superficial BCC on the face, then I think it's extremely important to warn the patient that they may get quite significant and fairly prolonged hypopigmentation, which may last for many months. There's just an example, the next slide, of the imiquimod information leaflet that's available, imiquimod being Aldara, that's available to easily download from the BAD website. The next slide is about triage and follow-up. You need to have very robust systems in place for triage and follow-ups. Follow-ups particularly are a big issue. We've taken to writing to patients who we've seen in the skin cancer clinic who we've removed benign lesions from, but I think it's extremely important that these letters are carefully constructed, they contain the right amount of information for the patient, and I also think it's extremely important that the benign lesion letter is written with the histology and the last clinic letter available, because otherwise it's easy to not realise that your biopsy has been unrepresentative. It's also sometimes easy to not realise that the patient was already under the care of the dermatology service for something else. They've developed a new lesion, we've biopsied it, it's benign, but in fact they need to receive a follow-up appointment. If you just do a benign lesion letter, then you may write to them and discharge them when in fact they were still on melanoma or squamous cell carcinoma follow-up. This is one of our triage sheets, and what we do with the service in Bradford is that we get the histology, we get this sheet, and we get the last clinic letter, and we will annotate on this sheet whether a benign lesion letter can be sent, whether a fully excised basal cell carcinoma letter can be sent, or if the patient needs follow-up, which clinic they need follow-up in, and also whether what the timing of that follow-up should be, and whether they need to go on to the MDT. And generally speaking, this works extremely well. I'm going to move on very briefly to dermoscopy. I have to admit that I'm not the world's keenest dermoscopist. Again, I think that some of the changes that one sees with dermoscopy can be extremely subtle, and there is a need for a lot of practice in using a dermatoscope, which is the top of these two instruments, because sometimes the features that you're looking for can be extremely subtle. There are many tutorials out there on the internet, and I felt rather than spending ages going through these subtle features, I think if people want to learn a lot about dermoscopy, then doing one of those tutorials on the internet. There are some relatively cheap small paperback textbooks on dermoscopy which have got a CD-ROM with them, which have got lots of illustrations of the sort of changes you're looking for with dermoscopy. I have to say that I also use a magnifying glass, because I think you can see many of these subtle colour changes with a magnifying glass, but I think what you can also see with a magnifying glass, particularly if it's well lit with LED, is you can see surface changes, and I think sometimes the surface changes are as helpful as the pigmentary changes. That of course is a personal opinion. What I think can be an issue in very busy fast track clinics is that people ignore the patient and focus on the lesion. And I've had a number of negligence cases where a junior doctor has seen a lesion. The consultant or senior in the clinic has briefly gone in to look at the lesion, waving a dermatoscope about, had a look at it, thought it was harmless, and really not listened to the history and talked to the patient at all. And clearly changing lesions, variable pigmentation and new lesion are all extremely important factors, and in my considered opinion much more important than the dermoscopic features. Ardent dermoscopists will have their own arguments, but I think dermoscopy, this is the next slide, pros and cons, needs great experience. I do not think it's a substitute for taking an accurate history, and sometimes the changes can be extremely subtle. I think the issue comes down, and I've just got two examples from dermoscopy. This is a dermoscopic picture of a lesion which is clearly got many features that would make you think that it was a melanoma just from looking at it, its size, its shape, and it's got variable colour, and I cannot really see why you need to look at that with a dermatoscope to know that it's got all the features of a melanoma. The next, and there's another picture there of a lesion under dermoscopy, which again has irregularity of shape and colour. It's not a gross set of changes, but it is, and I've gone back to that for a minute. It's not a gross set of changes, but clearly there are many features here which would worry you about this lesion. The next one, again, you could look at that with a dermatoscope closely, but it's got variable colour and variable shape. It's on the sole of the foot, and I think again that's really no need for dermoscopy in order to know that that's a melanoma. This last slide that I looked on the internet to see if I could find something which was an example of how dermoscopy can be of benefit, and this is an example that was put forward by an American dermatologist who was very keen on dermoscopy. And basically this is the best close-up of the lesion I could get without the dermatoscope. But what the dermatologist did say is that this lesion showed what we often describe as the ugly duckling sign. In other words, this was the patient's virtually only mole of any significant size on a background of freckling. I think that when you look at this from a distance, and it's almost certainly over 5 or 7 millimeters, it's got some variability of pigmentation. When you look at it closely, it's got some of the features that are described by ardent dermoscopists as subtle features of a melanoma. But again, I think this is taking things to extreme, because we've got something that's showing the ugly duckling sign. The lesion had grown recently, it's got an irregular shape, and it's got irregular colour pattern, and I think all of those are features that could be discerned without a dermatoscope but with a magnifying glass. But I think all of you should probably do a course on dermoscopy at some stage in order to make your own opinions on how valuable it is. So I'm going to close that's the end of my talk. As I say, if anybody wants to ask any questions or contact me about anything in here, it's andrew.wright@bthft.nhs.uk. Thank you.